This was a talk I put together for a group of nurses who I work with, and it's about back pain. And then I followed it up with pretty much my radiculopathy lecture. So I'm going to do the first half and then refer you to the radiculopathy lecture, which should be elsewhere. Okay, nurses, I made this just for you, and it's all of my secrets, all of the tricks of the trade, which get me my outcomes and my 5-star ratings. After defining it, you'll get quick insights into what I do when I see a patient with low back pain. Then I'll explain what the imaging really means, and finally give you the science of the notorious pinched nerves everyone talks about. Finally, I'll share what's actually going on with most low back pain and what the member really needs to do for their back. First of all, the low back is everything between the bottom of the ribs and your butt. Second, low back pain is a complaint, not a diagnosis. An ER doctor would be fired for writing chest pain as the diagnosis, yet many people leave it at that with the back. What's causing the back pain is more important, yet you'll see notes with back pain as the diagnosis. Sometimes there's an obvious cause, like in Batman's case here, as Bane snaps his spine in half, but most of our consults at this service that I was talking at are not that easy. It's important to know that most back pain gets better in 6 weeks, whether you treat it or not. 1 to 2/3 will recur, and when it does, it's usually because you had back pain before. Back pain is very common, and it is disabling. Globally, low back pain contributes to economic inequality and seems to preferentially affect poverty. Our clients in this place that I work at, they care because it's costly to the system in treatment and lost work hours. Most studies actually underestimate the total cost of low back pain. A large part of this cost problem is that we're not very smart about how we handle it here in the US. In the Netherlands, costs were substantially reduced after legislation that reduced disability pensions and after applying evidence-based criteria for medical practices. When a patient sees me for low back pain, there's a little triage nurse sitting on my shoulder, whispering this slide into my ear because it can be the herald of some scary things like cancer, fracture, and infection. These are all outside my wheelhouse and are all sent to the ER. It's one of these things that occur that I can be helpful, and I break that down further for you later. To really drive home these urgent issues first, this is the stuff that should never come to us in the group that I work in, because it should already have been adequately addressed by a surgeon. This shows you unstable fractures of different kinds, deadly disc infections, and unstable motion or fracture of the bone. Cauda Aquinas syndrome is another concerning diagnosis that deserves some attention. Basically, all of the nerves at the bottom of the spine are compressed, causing paralysis and incontinence. This needs surgery. So hopefully I've now addressed one of your submitted questions, which they had submitted, which was how I decide who needs surgery. Here it is. If they have any of the diagnoses I've mentioned or complain of these, what are referred to as red flag symptoms, I send them for surgery. I inform them that any other reason that you go to surgery is technically considered an elective indication. We'll come back to surgery later when we talk about treatments, but for now I'd like to move back to what I'm thinking when they first present to me. So now we can move to the stuff that actually walks into my office and doesn't need to go to the ER. Based on history and examination, I'll try to identify a neurological cause. If not, then we try to look for pattern to the pain complaints. Does it worsen with flexion or extension, bending forward or backward? Unfortunately, most people don't actually fit into any neat little, tidy little pattern, which is why this becomes such a challenging diagnostic issue for the majority of our healthcare system. This slide acknowledges that what we know, but no patient ever hears because it's not addressed by prescribing a pill or providing a procedure. That is, that the development of low back pain is likely the result of a complex set of existing influences. This table shows you factors that we already have great evidence for, but no patient member really cares to get into this. They just want you to pop the hood and tell them what component of the engine is causing their pain and who's going to fix it or replace it for them. So that's why I don't bring this stuff up in my consults until We're close to the end of the visit. Instead, I embrace that car parts mentality and teach them some anatomy. So let's remind ourselves of the anatomy. The spine is a stack of bones called vertebrae that protects and encases the nerves. Between the vertebrae are the discs and nerves coming out. This is what almost all my patients are most concerned with. The spine sits on the pelvis, which is comprised of the sacrum and ilium, and these together form the SI joints. Along with the ball and socket hip joints, these are all quite close together and can require some skill on exam to distinguish as pain generators. These are all covered by ligaments, muscles, and tendons, which can all cause pain. Deep inside, there are muscles connecting the stack to each other that no one ever talks about. Even though it's an oversimplification, I usually tell my patients that the disc is like a jelly donut, the annulus is the dough, and the nucleus pulposus is the jelly. So if we're looking from the side here, which would be the same as a sagittal MRI, the discs and vertebrae should look neatly aligned. When the dough of the jelly donut is out beyond the margins of the bones, that's what's called a disc bulge. That's clinically meaningless to me. Bulges are seen in 30% of those 20 years of age and 84% of those 80 years of age. Disc herniations are the ones where the jelly squirts out. And the jelly is constantly squirting out in all of us. I've reviewed almost 100 scientific studies at this point that show a significant number of disc herniations in asymptomatic patients. That means you MRI someone with no pain and there's a likelihood of seeing a herniation. The percentages are about the same as the age. So 20% of people in their 20s will have disc herniations, 30% in their 30s, all the way up to 80% in their 80s. One study found 90% in the 20s. I think this is important for the patient to hear so that they don't fixate on the MRI findings, which unfortunately happens when they meet a surgeon. So on the MRI, there are different categories of disc herniations, which are important for you to know because they carry different clinical prognoses. Protrusion is when the jelly hasn't quite made it out of the dough. Extrusion is when it has. And sequestration is when it's lost connection to the parent disc. This verbiage is now standardized by a giant task force and used by everyone the same way after decades of people arbitrarily using words to describe what they saw. Here's a smaller disc space suggesting loss of jelly over the years. Here's a herniation on sagittal and axial MRI. Lumbar disc herniation can regress or disappear spontaneously without surgical intervention. There are 3 theories of how this happens. Number 1, the donut sucks the jelly back in. Number 2, the jelly dehydrates, or what's probably happening is that the body gobbles it up. And it's interesting because the worse the herniation, the better the chances it'll disappear. So now that we've addressed the patient, I've got a disc, I want to address the arthritic spine. The word spondylosis for you guys is as good as spine arthritis. It's wear and tear, drying out, spurring, and just plain yuck on X-ray and MRI. And all of this stuff just keeps adding on every decade you get older. Multiple studies have shown that these are not associated with disability or back pain severity. So I essentially tell my patients seeing this stuff is like gray hair and wrinkles. This is why multiple professional organizations have strong positions against imaging for back pain. It really doesn't help. But the problem for us is that our patients are fixated on their imaging findings because their surgeons are fixated on them. The reasons the surgeons are fixated on them is that it determines which surgical procedures they can offer, and surgeons offer surgery. So I tell my patients very honestly, no matter how smart and compassionate your surgeon is, when you have a hammer, everything sometimes looks like a nail. And that's why I'm successful at steering my patients away from spine surgery. It is evidence-based, it is compassionate, and it is super important for everyone in the healthcare system to know as soon as possible. So now is when I had a Q&A session, and then I followed it up with basically the slides from the radiculopathy lecture. So I am going to ask you to go to that. And yeah, hope you enjoyed.